Hi, I'm Keith Barton. These are my financial disclosures. The role of the glaucoma specialist in managing uveitis is to manage angle closure and to take pressure out of the equation so that the uveitis specialist can manage the inflammation properly. Surgery is often required and the glaucoma surgeon must be familiar with the full portfolio of glaucoma surgery. Angle closure requires special consideration. There are three broad mechanisms: pupil block, chronic synechial closure, and anterior chamber shallowing. The relative pupil block of primary angle closure is very different from the absolute pupil block of uveitic glaucoma. How does it differ? The absolute pupil block in uveitis is more dramatic, and often the iris is stuck to cornea, not just trabecular meshwork. Moreover, the sticky aqueous means that laser iridotomy does not relieve the pupil block adequately. The iris is often still stuck to trabecular meshwork. Surgical iridectomy is also more often required as laser iridotomy holes may close. This paper in the BJO, accompanied by an editorial by Gary Hall and myself, highlight the poor success rate of laser iridotomy in uveitic glaucoma. This patient is a good example of the problem. 3 patent laser iridotomies. The iris bombae has resolved, but the angle is completely closed and the pressure is high. Surgical iridectomy offers the opportunity to open the drainage angle with viscoelastic. I'm not breaking synechii here, simply opening reversible contact between trabecular meshwork and the iris. Using 23 gauge vitrectomy forceps and scissors, an iridectomy is performed. Surgical iridectomy is generally larger than laser iridotomy and less likely to close. Surgical iridectomy with viscogoniosynechiolisis therefore prevents the development of this scenario. What about actual physical goniosynechiolisis? So generally, breaking PAS is not recommended. So that's pupil block. Chronic angle closure. Well, chronic synechial angle closure I use as a predictor of chronicity. I use 3 factors to predict the chronicity of the IOP problem, i.e. the likelihood the patient is going to need surgery. The first is evidence of chronic angle damage, such as synechii. The second is when they start to develop disc asymmetry in a young person who has had episodic high pressure levels. And the third is pattern recognition. Some patients just have types of uveitis that are more likely to have chronic pressure elevation, especially infective causes. Anterior chamber shallowing from forward movement of the lens IS diaphragm, or phacomorphic glaucoma. Typically, there's a very shallow central anterior chamber. Most cases are iatrogenic, but inflammatory causes such as posterior scleritis and VKH are obviously very well known, and the treatment is to treat the cause. What about IOP lowering surgery? Well, trabeculectomy has a bad history in uveitis. Tubes, on the other hand, work well in uveitics. However, the bad press for trabeculectomy is not completely deserved. In this audit of mitomycin trabeculectomies at Moorfields, we found that in carefully selected cases, the success rate was actually very high at around 80% after a median of 4 years. The one big predictor of failure was actually pseudophakia. In fact, ethnicity and type of uveitis were not failure predictors. However, if you're performing trabeculectomies in uveitis, it's worth adding extra sutures as there is a higher risk of hypotony. This is a publication reports a series of XENs and was published in Clinical Experimental Ophthalmology in 2018. We have also presented a series of Infocus Microshots in uveitis at the American Glaucoma Society this year. Results of subconjunctival MIGS in uveitis mirror the difference between MIGS and TRABs in POAG. In other words, they're reasonably successful but less successful in TRABs. And in those with high IOP but mild glaucoma, I will do subconjunctival MIGS. In those with bad glaucoma, I'll do a TRAB. I must emphasize these are patients with no failure risk factors. If there are failure risk factors, then really it's a tube. These might be a mixture of ethnicity, single chamber eye, neovascularization. JIA patients, I will do exclusively tubes and not TRABs. Tubes have been shown historically to work well in uveitis, but it is not a case of one size fits all. My go-to tube is the Barvelt 101-350, even in uveitis. But there are certain types of uveitis, such as JIA or any severe chronic uveitis from early childhood, where the 101-350 carries a high risk of hypotony. In that situation, I will generally use the single plate Maltino if the patient's had very severe uveitis from early childhood, or a Barvelt 250 or perhaps an Amid valve if slightly less severe, but even these can be too much from the very severe JIA patients. The single plate Maltino implant therefore has not yet been quite consigned to the history books. So finally, what else do I do when? I do not reduce steroid treatment just to reduce the pressure. And I do operate to try and take pressure out of the equation of the uveitis specialist when it's necessary. Thank you very much for your attention.